debate about. So just when in doubt, call Lori or myself, and we can talk it through. Lori usually will ask some good questions. It's related to care planning and so forth. So when in doubt, call.
And let you know if you've talked to me, right? Isn't that what you?
Yeah. So if I don't answer, leave a message and I will call back.
So now we'll talk a little bit more about reporting reasonable suspicion of a crime. So this is kind of a gray area too, because what is a crime? Isn't all vulnerable adult situations a crime? Not necessarily. Theft, I would definitely consider that a crime. And then we'll kind of talk about how to report and when to report that kind of stuff. An injury related to a fall, that necessarily would not be considered a crime. Even if it wasn't following the care plan, it's not necessarily a crime. Now, if somebody pushed somebody purposely with intent to hurt them or to really hurt them, that could maybe be considered a crime. I would probably report that to local law enforcement. So when you have suspicion that a crime occurred, then not only are you going to be reporting it to OHFC, I did write MDH there for the Minnesota Department of Health, but it's kind of the same thing. You're also going to be reporting it to the local law enforcement. Okay, so then this is really kind of a time frame, because if you have 24 hours to report, it has to be done immediately, but within 24 hours. But if that injury or that crime, I should say, resulted in physical abuse or it was sexual abuse, where it involves serious bodily injury to the individual, then you have 2 hours. You need to make that report right away to local law enforcement and to OHFC. I mean, can't be any hesitation. If you see that sexual abuse occurred, you don't, like Lori said, wait for your med pass to finish. You don't wait for supper to end or till all the residents are in bed, till you have some free time. You need to stop what you're doing and you need to make that report. You need to call Tim and Lori, let them know, and then you need to file the report and call local law enforcement. You can't really have time to think it through. It needs to be reported right away. And that's not just St. William's rules. I mean, this is, federally regulated rule for all nursing homes. So when there is not any serious bodily injury, then like I said, you have 24 hours to report. So these types of examples would be, like theft, or you believe financial exploitation is occurring. Maybe you believe a family member is spending a resident's money or taking it out of their room without that resident's consent and using it for their own personal means to buy whatever they want, not for the resident. So here again, all vulnerable adult incidences must be reported immediately to the administrator and indicated on the OHFC report. So this again is more for nursing, because they're the ones that are going to be doing the reports if me, Tim, and Lori aren't available. So again, more for nursing. There's information in the RN office on how to file a vulnerable adult report. There's a booklet in there, kind of goes step by step. We have our policy in there. We have information about reporting reasonable suspicion of crime, reporting to local law enforcement, the phone numbers, all that information is in there. And then this is for all staff for reporting a vulnerable adult incident. There's information in the break room, for OHFC and how to report and the numbers to call if you are concerned. So that might be true too, if you're at home and you have a neighbor who you're worried about and you want to file a report, you can call local, county social services, you can ask me, but you can also get that information too from the break room. It's posted in there. So now we'll talk a little bit about dementia, and these are the objectives. So quick explanation of Alzheimer's disease and other related disorders. communicating with persons who have dementia, assisting with activities of daily living. So that would be helping a resident with dementia with bathing, dressing, hygiene, those types of things, and also problem solving with challenging behaviors. So the definition of dementia is that it's a chronic and persistent disorder caused by a brain disease or an injury that produces a decline in memory and intellect from some previously higher level of functioning that's severe enough to interfere with everyday life. So a lot of times we throw around the word Alzheimer's disease. Alzheimer's disease is a type of dementia. So the best way for me to picture it is dementia is the top of the umbrella, and underneath it are a bunch of different dementia-related disorders. So you have Alzheimer's disease, you have frontotemporal dementia, vascular dementia, and many, many other types of dementia. So the most common cause of dementia is Alzheimer's disease. So approximately 50 to 80% are due to Alzheimer's. So I think that's why, you know, we throw those words around interchangeably so often. So the type of symptoms you're going to see with somebody who has Alzheimer's is you're going to see more of a slow progressive decline. That's where you see, you know, the short-term memory usually happens first, and they still have their long-term memory, and gradually it goes back. The memory loss goes back, it progresses. You might see some behavior changes, some loss of initiative. Alzheimer's disease is not reversible, and it is fatal. It's actually, right now, the 6th leading cause of death in the United States. So frontotemporal dementia, there's a picture of the brain, and you can see where the frontal lobe is of the brain and what that frontal lobe of the brain does. So there you have like your executive functions, your thinking, planning, organizing, problem solving, those types of things. So you're going to see somebody who has this type of dementia start to lose track of time, to manage their checkbook, to remember details, to plan and organize things. You also might see more changes in their personality. Maybe somebody who's never sworn in their life all of a sudden starts swearing a lot because they don't have the ability, to realize, that's what they're doing. The 4th most common type of dementia, and it typically begins before age 60. So then there's dementia with Lewy bodies, and this is probably a tougher one to diagnose. You're going to see varying levels of memory impairment. A lot of times you're going to see some of the Parkinson-related symptoms, so like a hunched posture, balance problems, rigid muscles, maybe some shuffling, when they're walking. You're going to see more visual hallucinations, delusions, and trouble interpreting visual information. So their confusion and alertness can vary significantly from one time of day to another, or from one day to the next. So vascular dementia is often caused by brain damage from impaired blood flow to your brain. So an example of that would be a stroke. You're going to see symptoms like problems with reasoning, planning, judgment, memory, and other thought processes. There are several different types of vascular dementias, and it depends on which part of the brain has been affected, and cardiovascular risk factors contribute to this. So we kind of know that, when you have high blood pressure, stuff like that, it increases your chances of getting like heart disease or having a stroke. Other causes, so just about any condition that causes damage to the brain or nerve cells can cause a dementia. So like for people with Parkinson's, they'll often exhibit dementia in the later stages of their illness. Sometimes, not all are irreversible. Sometimes they can be reversed, so it kind of depends. I mean, so like a change in your cognition, like somebody who has a urinary tract infection, you might see some more changes in their behavior, more confusion, things like that. You're going to think of it as a dementia, and it kind of is a symptom of dementia, but it's a reversible one. When they get treated, their memory functions, their cognition goes back to their baseline. So Alzheimer's disease and other dementias, they gradually diminish a person's ability to communicate. Communicating with a person who has Alzheimer's or a different dementia requires a lot of patience, a lot of understanding, and good listening skills. And I know it can be really tough. So the changes are going to be unique to each individual. In the earlier stages of dementia, the person's communication may not seem very different. They might start repeating words or having a problem finding the right word. But then as the disease progresses, you might recognize that they're using familiar words more frequently. Maybe they're inventing new words to describe familiar objects. Maybe they're reverting back to their native language. And you're going to maybe see that they're having difficulty organizing words logically. And sometimes maybe they're even speaking less often, because maybe they realize that, something's going on, and instead of talking like they used to always talk, they're going to just speak less often because they know that they can't get the right words out. So there are things that we can do to help the person who has Alzheimer's or a different dementia communicate. So does anyone want to maybe volunteer some things that have worked for them? What are ways that we can help a resident communicate with us? So these are some of the things that we can do. I think a big one here is actually limiting distractions, because I think that when you have a lot of commotion going on in the hallways, you're trying to talk to a resident who has a dementia, you're not going to have a very good chance of communicating good with them when there's a lot of commotion going on. Another good one is, focusing on feelings, not facts. When a resident says, that they're looking for their mother, and you know that their mother has died 30 years ago, instead of saying, your mom's dead, she died 30 years ago. Talk to her about her mother. What was your mother like? What do you miss most about her? Does anyone have any comments about these? Anything that's worked for them? Any stories they want to share? So there are things that we can do too to better communicate. One of those things is identifying yourself. So when you're going into a resident's room and you're knocking on the door, introduce yourself. Especially when a person who has dementia, and you do this with them, they're gonna maybe feel a little bit more comfortable talking to you, because they know that you know them. Even though they don't know you, they're gonna feel maybe a little bit more comfortable because you just call them by their name, and that's gonna kind of reassure them that, hey, this person knows me, I can kind of relax and talk to them. Use their name. Don't call them sweetie or dear or honey, call them by their first name, be respectful, introduce yourself. Use short, simple words and sentences. They're gonna have a really tough time understanding you if you just start blabbering on about needing to take them to the bathroom to go take a bath, and then you're gonna bring them to their room and you're gonna put lotion on them and you're gonna get them dressed, and then they're gonna be ready for breakfast. Okay, I heard breakfast, you know, I mean, what, we're going to breakfast? You know, say, hey, you know, are you ready for your bath? I can help bring you there. Leave it at that. And when you're in the bathroom, you know, tell them, no, I can bring you to your room and help put some lotion on you. Speak slowly. If you're asking a resident a question, give them time to respond. Emerson is one that I think of that comes to mind when I think of that one, because he is able to often respond, but he takes a little while. Try to turn questions into answers. So instead of maybe saying, hey, are you ready for your bath? Say, hey, I'm here. I'm here to help you take a bath. I can bring you there. You know, why don't you come with me? Try to turn negative things into positives. You know, nobody likes being told what they can't do. You know, you're chasing after them down the hallway because they're trying to leave the facility and you're saying, yo, you can't go out there. No, you can't. Why not? I've been going out there all my life. You know, try to redirect them and say, hey, you know, we have bingo going on right now. Why don't you come with me for a little bit and then we can go outside. Then we can go look for your car. You can try giving visual cues. Always treat the person with respect and dignity. You can try writing things down. You know, I know visual cues would be like if they have to go to the bathroom, sometimes, you know, having a picture of a bathroom, of a toilet helps. So there are a lot of things that we can do to help communicate with people who have dementia. And being able to communicate with people who have dementia is going to help a lot when you're helping them with their activities of daily living. So as the disease progresses, you're going to see that they need more help with their activities of daily living. So like eating, dressing, basic hygiene, toileting will all be likely neglected as routines are forgotten and their ability to do those things deteriorate. Some of the behaviors that we often see with people who have Alzheimer's disease or other dementias is anxiety, irritability, anger, aggression, apathy. Maybe they just don't seem to care about anything anymore. Withdrawal. You know, and it's likely that some of these behaviors are to some extent the result of the person's ability to recognize that their ability to do these things is deteriorating. I mean, I think that would cause me a lot of anxiety and I'd probably become irritable and have a hard time with that. So we kind of have to remember what that resident is going through and work with them on that. Be there for them. You know, try to understand that behavior as a form of communication. They're not able to express their needs anymore. They're not able to say, hey, I need to use the bathroom. Where is it? When they have to go to the bathroom, they have no idea where the bathroom is. They maybe don't even know that they have to go to the bathroom. They're maybe just sitting there and they're anxious, they're uncomfortable, they're, you know, agitated, they're maybe wandering, you know. So you have to start kind of being a detective and trying to rule out, you know, try to figure out what they need, or what you've just given them. Maybe, you know, you just took them to the bathroom, they just went, so that's probably not it. Maybe they're really hot, maybe they're cold, maybe they're hungry. And often behavior tells us about how a resident is feeling, you know. Maybe they're feeling sad, maybe they're feeling lonely, maybe they're feeling bored. And let's not look at behaviors as being difficult or as a problem. You know, try to look at it as a form of communication. So most behaviors exhibited by a resident with dementia is an attempt to express their feelings and needs due to the loss of their language skills. It's important for us as staff to learn and understand the common behavioral symptoms that accompany dementia and to identify the most effective interventions to help minimize the behavior and to improve their quality of life. what works for one resident isn't always going to work for the other, and it's not always going to work again for that same resident that it worked with,